All right, it's 12:45. We'll get us started. Thank you, everybody, for joining us. Good afternoon. I'm Scott Wilson, the Regional Trauma System Coordinator with Metro Atlanta Trauma Advisory Committee. Welcome to the MTAC Monthly Trauma Conference. Please be sure to mute your mics and complete an eval so we know how the session was. I'll be posting that info in the chat box. We hold this conference on the third Tuesday of each month on varying topics related to trauma, so we hope you'll join us again in the future. Check out our website, metroatlantatrauma.org, for more trauma education info, or follow us on social media, Twitter, Facebook, Instagram, and LinkedIn. Now I'll turn it over to Dr. Miles and our panel. Thanks for joining us.
Sarah, do you have the slide set?
Yeah, they're being shared. Can you guys see them okay?
No.
Yeah, hey, it's Joe Bernard. Can you guys hear me?
Can.
Yes, Joe, we can hear you.
Awesome. All right, thank you.
And Sarah, I can see the presentation.
Right. Dr. Miles, it looks like you took control and are, yeah. Do you want to go ahead and share slides yourself?
No, if you can take it back, or.
Okay, yeah. I think you have to allow up at the top. Yep.
For some reason, I could not see any of the slides.
Okay. Just 1 second and I'll share again. All right, perfect.
This is the nature of the current virtual presentations, but you appreciate everything, and thank you, Scott, for arranging all of this. This is going to be a unique presentation because there are several people presenting, but it's very important to get the perspective of the different disciplines involved around these topics. I want to welcome all of the December's MTAC audience where we are presenting this really ever dynamic topic and the work that's really taken several years to turn the culture of management of the small dots and spots of blood in both traumatic and non-traumatic bleeds into a more evidence-based approach throughout this healthcare system. Next slide. I want to mention that there are no disclosures related to this topic from any of the panelists that are presenting. And for the audience, you'll see us try to transition between some of the slides. You see some of our names up there. That's part of the way we're trying to transition in this virtual platform with everyone sort of spread out. Thank you. Next slide. These are the objectives. This is very important to understand the different components around this topic. There are many nuances in how to achieve this goal and of the evidence-based approach and management and to streamline the process. We hope to be able to make the audience understand the burden to the community and health system with transport of patients with traumatic and non-traumatic intracranial hemorrhage that may not have needed to be transported. Review the history of the guideline development for intracranial hemorrhage patients where a culture of management required the radical change in approach and it really required strong consensus building. To describe the new Cerner Power Form developed with the help of Matt Sullivan and his IT team, along with the core disciplines that will help, this Power Form will help populate all the information around the brain injury guidelines for TBI, as well as the guidelines for intracranial hemorrhage. It will put it into a note and provide guideline management goals. We also will discuss the process improvement development at this time where it was developed during all the pandemic restraints and the resources required. Next slide. This is really the part of the core group of the TBI Intracranial Hemorrhage Workgroup that really began from a discussion with Scott Lindblom at one of our neurosurgical ICU critical care committees. And there's so many other people that have been involved over the past several years, but as we have taken this project and moved it forward, there's myself, and these presenters, myself, I've been part of Atrium Health now for 25 plus years, one of the professors of acute care surgery in the system, and part of the neurosciences in the sense of working with the neurosurgical ICU. Joe Bernard, who is part of the Carolinas Neurosurgical and Spine. He's one of their interventionalist specialists for stroke and former chief of staff for Atrium Health. Ben Morrell, who is an emergency medicine physician in the system, was a graduate of CMC, medical director currently of USA Acute Care Solutions and the medical director of the Pineville ED. Lauren Macco, who has been part of the Neurosciences Institute and part of the critical care system. She's a clinical nurse specialist, part of the Carolina Stroke Network and Neurosciences Institute. And Sarah Bender, who is the director of neurosciences and the musculoskeletal institutes with Atrium Health. And I have to mention Mike Behringer and Michael Thomas, and most everyone in MTAC know these two. They were part of the Carolinas Trauma Network. Thomason has retired. Mike Behringer is still currently working with Atrium Health, and they've been part of this. We're going to discuss a lot today, as mentioned on the slide. So hopefully this presentation will really get into all these different topics. Next slide. I have to mention the collaborative effort between these three institutions and centers. Atrium Health FH Sammy Ross Trauma Center is a very important component within the MTAC system, of course, as the advisory component. Atrium Health Neurosciences Institute that was created several years ago and has been a huge component for Atrium Health and outside of Atrium in becoming one of the comprehensive stroke networks and working with all the other facilities for the stroke and spine institutes. And of course, Carolina Neurosurgical and Spine Associates, who have been is one of the largest neurosurgical groups in the country, but have also been huge in the collaboration and working for the best care of these patients. Next slide. And as mentioned, with Carolina Neurosurgical and Spine, 22 full-time neurosurgical faculty, they've been part of the cutting edge medical management and surgical management for a lot of the neurosciences diseases. They've been excellent to work with and collaborate and consensus build to help with our trauma patients. Next slide. And the Metrolina Trauma Advisory Committee, like everyone knows on the audience, it's really one of 8 total advisory committees in the state around the National Verified Committee on Trauma Centers. Huge resource of information around trauma. As you know, Ron Singh, the medical director, Scott Wilson, the coordinator, here to help and to help with advisory around the topics of trauma. Of note, Dr. Singh did present this topic with minimal traumatic brain injury a few years ago, and I did borrow some of these slides, such as this one, from him. Next slide. Want to mention a little bit about the background and history of the project. CMC is a quaternary referral center to Atrium Health. We were looking at avoidable transfers, frequently looked at from a capacity management and patient experience. The discussions around ICH and TBI really began in 2012. Like I mentioned with that conversation with Scott Lindblom. And why has it taken 8 years? Really, the culture change and growth and evolution of the management around the system, with meeting several of the concerns and the barriers early, which is really the comfort of the local MDs and the expertise of the different providers around these disease processes. And you have to remember that prior to starting this process, the community culture that was fostered was really send to Maine, CMC Maine, every one of your sick and injured patients. And with that, that was the current culture at the time, and we had to sort of change that based on the evidence-based management around traumatic and non-traumatic intracranial hemorrhage. Next slide. So when we're talking about intracranial hemorrhage, we were mentioning traumatic and non-traumatic, and we were looking at the evidence around these. What we realized in the very beginning that the transfers were really more related to non-traumatic intracranial hemorrhage versus the traumatic ones at that time. But if you look at the non-traumatic intracranial hemorrhage, and we'll mention why we are lumping those together in this presentation, but if you're looking at non-traumatic intracranial hemorrhage, intracerebral hemorrhage accounts for 8 to 13% of all strokes. And what does that mean? We're talking about hypertension, we're talking about subarachnoid hemorrhage, we're talking about any type of embolic kind of stroke that could subsequently cause intracranial hemorrhage. And there are many procedural management around these hemorrhages that need to be addressed. Majority of these are actually small spots and dots, or they can be very severe and are futile in recovery. Next slide. When we talk about aneurysmal subarachnoid, and I want to mention that, everyone understands it's the worst headache ever. There are multiple other findings. It is a medical emergency, and it's a little different than some of the other non-traumatic intracranial hemorrhages in that majority of these patients will require transfer to a higher level of care for definitive management. And with Carolina Neurosurgical and Spine and the Neurosciences Institute, they have a great system to help manage these patients, and majority of them will need to be transferred. Next slide. And of course, when we talk about traumatic intracranial hemorrhage, we're talking about all of these plus others with subdurals and epidurals and interventricular and subarachnoid. And most of these that are severe based on the brain injury guidelines, which we will be getting into, will need to be transferred or communicated to or with the different specialists in the system. But some of the minor ones, or perhaps the futile severe ones with the DNR, DNI, those are the ones we are trying to address based on the guidelines and a need for transport. Next slide. So, like I mentioned in the beginning, the ICH data showed over 500 patients a year transferred to CMC, and it was all sizes of intracranial hemorrhage. And when we took over some of the minimal brain injury work that Mike Behringer, Mike Thomason did around 2015, 2016, the TBI data at that time for isolated TBI were actually smaller than ICH. And it's interesting, over the last 5 years that has changed, as we will show some of the data. But what we realized that even at that time and before then, the majority of patients that were being transferred to CMC with traumatic brain injuries were actually several minor traumatic brain injuries. Next slide. So I'm going to go in some of the data and research, both outside and within this institution. We looked at in evaluating evidence base. The Queens Hospital Medical Center in Hawaii had guidelines looking at transporting patients with small and minor head bleeds. And as most of us may realize, that Hawaii is made up of several islands, and with transporting patients to Queens Hospital in the major island, it would cost extreme resources to transport every single patient. And they set up guidelines in 2007 and published it several times. And they basically said, isolated non-depressed skull fractures, isolated pneumocephalus, solitary cerebral contusions, minor subarachnoid, etc., subdurals and epidurals really do not need to be transported to Queens Medical Center and could be managed with the resources at those outside other island medical centers, and they set up the resources and ability and education for that. Next slide. Dr. Nguyen, also part of Atrium Health and one of our partners, published this in 2001, looking at utility of neurosurgical consultation for mild traumatic brain injury, and really looking at abnormal CTs with Glasgow Coma Scale of 15 and looking at contusions, subdurals, and subarachnoids. Next slide. With the CT characteristics, what we looked at was a repeat head CT done at 24 hours and comparing it to the first one, looking at this and seeing a % change in findings of the CT versus the relation of the patient and the Glasgow Coma Scale. And what it showed was that this breakdown was how many were subdurals, how many were epidurals, how many were contusions versus subarachnoid. And contusion and subarachnoid did make up the majority of them, with subdurals being less than 4 millimeters, contusions less than 5, and minor subarachnoids. Next slide. And with at the time of the repeat head CT, it shows the % change in findings, and it shows that 9% of the patients improved, only 7% got worse, and over 80% of patients, there really wasn't any change on the CT or in their neurologic condition. Next slide. And with this, the outcome of the Worsen CT, of 4 of the patients with the Worsen CT had decrease in GCS Glasgow Coma Scale from 15 to 14. One patient had a mannitol order for focal edema, and what was evident with this research showed that no patient required a neurosurgical intervention at all. And next slide. The question really comes, do we really need neurosurgical consultation, and with that, transportation? And that was some of the early work in early 2000. Next slide. Especially around the Glasgow Coma Scale of 15, even with an abnormal CT finding, with neurological examinations, when mandatory neurosurgical consultation was not required in the transport, just with consultations and subsequent visits is a $65,000 savings, and that doesn't put into, at that time, 19 years ago, doesn't put into the context of transport cost and other things related to that patient's care. Next slide. There was also research this recently published with Dr. Singh and Dr. Bernard and company looking at the novel CT, which is really a novel CT, for those who may not understand, splits full C-ray beams into smaller beams and really has better delineation and better imaging. And what that showed was defines better the minor TBI, traumatic brain injury. And it really showed, identifies patients that can be managed without transfer, and really showed that you can improve cost-effective triage with a novel CT, and it gives more credence to that evidence that with the newer CT high resolution CAT scans, we can really help delineate the imagings to look at cost-effective strategies around triage and consultation. Next slide. And the work done by Joseph Bilal was published looking at improving cost and quality with the traumatic brain injuries around the brain injury guidelines. And after implementation of the brain injury guidelines, they looked at patients with suspected TBI. They underwent initial CT scan of the head, and those with intracranial hemorrhage were evaluated by the acute care trauma surgeons, categorized into 3 brain injury guideline categories based on the patient's medical history and findings. Patients in the big 1 category, and we'll go into this further, were observed for 6 hours without any neurosurgical consultation or repeat head CT. And they defined abnormal neurologic examination findings as altered mental status, focal neurologic deficits, or abnormal findings from pupil examinations. Patients in the big 2 category were observed for 24 hours without a repeat head CT or neurosurgical consultation, and a neurologic examination was conducted every 2 hours. Patients who had findings of deterioration of clinical examination were upgraded to a higher category, et cetera. Next slide. This slide just defined the brain injury guidelines based on his research paper with the big 1, big 2, and big 3. And as you can see, it looked at loss of consciousness, neurologic examination findings, skull fracture, subdural, epidural, et cetera. And also looked at the therapeutic plan, whether hospitalization, repeat head CT, or neurosurgical consultation. And the more severe, of course, with the brain injury guideline category 3, they were and did have repeat head CTs, required more detailed and definitive hospitalization and evaluation with neurosurgery. Next slide. This slide shows the patient demographics pre and post implementation of the brain injury guideline process, and really shows the different components about the mechanism of injury versus the ISS, et cetera, and defined how many patients were in the different categories. Next slide. And this is the brain injury guideline category 1 sub-analysis, looking at the pre and post institution and how many in the group. And it really showed that in this category that patients really did not need a repeat head CT or neurosurgical consultation or hospitalization, and really didn't need that ICU length of care, and there were no issues with mortality or significant morbidity. And it really shows the implementation of these guidelines really did help with management of and triaging these patients. Next slide. So what it showed, like I said, majority of minor traumatic brain injury does not require neurosurgical consultation nor transport to level 1 or level 2 trauma center transfer. And really with the implementation of the brain injury guidelines. And when implementing these around the intracranial hemorrhage, we aligned it with the minor traumatic brain injury guidelines with the intracranial non-traumatic hemorrhage guidelines, really because the work around it, the people connected, the guidelines that are needed, the education that was needed at all, the Atrium Health facilities were very similar, and that's why we aligned these 2 processes. Next slide. Looking at our work group and the ICH TBI baseline data, it's really important because if you look at the data in the past, we had a conglomerate of different data sources from the ER, from trauma databases. They were really the work of different components of different places that we needed to pull together. And with the work around the Power BI, with the work around the trauma committee and trauma type databases at the 3 trauma centers within Atrium Health, which would be Cleveland Regional, Cabarrus, and CMC Maine, we were able to pull together a lot more information, which I'm going to go into the next few slides. And in starting a process like this, in developing and instituting this type of guideline project throughout a very large system, you need a lot of baseline data and which direction to go. And as evidenced by this slide, we needed to not just define the volume, but the opportunity and appropriateness. And as you can see, the number of traumatic brain injury patients that were seen and the non-traumatic intracranial hemorrhage patients actually switched over the last 5 years. And this data is from January 2019 and to October 2019. It showed the number of patients and percentage. And on that second or very bottom part of the categories, it breaks down to the different Atrium Health facilities, which really show the number of encounters and the percentage of transfers, and it shows the volumes differ by facility. And the larger Atrium Health facilities do have more transfers depending on if they were a part of a trauma center or not. Next slide. So the next two slides are just two of many I'm going to show, but are part of the Power BI database that Mike Behringer and the Neurosciences Institute worked on, utilizing the Committee on Trauma databases at the different facilities, along with the information around intracranial hemorrhage. And unlike when we first started this project several years ago, before 2015, we looked at just the education alone with streamlining processes, talking to the different groups around not only minor TBI, but also intracranial hemorrhage. A center such as Cleveland Regional actually started decreasing the number of their patient transfers. In the gray box, you can look that is the number of patients transferring. And this is combined minor TBI and intracranial hemorrhage both. But this also was similar when you broke it up into minor TBI alone and intracranial hemorrhage alone. I did not show those slides because we have so many others to talk about, but this does show that just by instituting, educating, talking before a true process has been triggered, you can start seeing results of the work. Next slide. And yet other centers like this one may show that, in one of many that can show that there's still work to be done and work around implementing these processes. And this is just one, like at Pineville, would show that even during that same length of time, that still some directed work can be instituted. Next slide. So I'm going to transition in a few minutes or a few seconds to Joe, but that in the criteria development, like I mentioned, the intracranial hemorrhage guidelines were created using most up-to-date literature and research with a similar format to the brain injury guidelines, which were instituted. And like I said, they had to be aligned work streams, and it took a lot more effort, but with the stroke network within Atrium Health, with the MTAC network within Atrium Health, the two groups really aligned and the stakeholders were very similar. So that's the reason why we did combine both. And Joe, if you're available to continue talking about the stakeholders as well as the criteria development.
Sure. Thanks for the opportunity. So we were trying to gather the similar groups of patients that would require some neurosurgical input on whether the patient would need to be transferred. And we have this a lot in intracerebral hemorrhage, and many of the same criteria that were used for BIG, we sort of shuffled and adapted and applied those to intracerebral hemorrhage in terms of volume calculations and that sort of stuff for what kind of patients would need to come. We had lots of different meetings with the ICU team, emergency department, nursing, critical care, and neurology. And very importantly for the hospitalist service, because at the outside hospitals, that's who we were going to be asking, along with the trauma surgeons, if they had them at their hospital, to help us manage these patients remotely. Next slide, please. So we also engage our radiology department. So Charlotte Radiology, especially Dr. Clemente heading that up, we're able to take templates of the descriptors for the big criteria, and now it's in all of the dictated reports performed by Charlotte Radiology. These are nearly real time. You know, the turnaround time for them is just a few minutes. In terms of the hospitalist group, Priya Joseph and Todd Schmitz and Ryan Brown were great to help us with this. And they are the ones that are taking the ICH and mild traumatic brain injury admissions at non-trauma facilities. There was a lot of education and process improvement put behind it, a lot of it championed by our leaders within neuroscience. Next slide. So let's dig into the weeds just a little bit for the brain injury criteria. So the way that it was originally described, there were three groups: Big 1, Big 2, and Big 3. We noticed in a lot of our patients, there were low doses of antiplatelet or anticoagulation that if we left the criteria the same, we would still have many opportunities for patients to be kept at their outside institutions that probably wouldn't need to come. So we created Big 2A as a category, the A for anticoagulation. And patients who were on aspirin alone or dipyridamol, or they were on anticoagulation with warfarin. And if their INR was below therapeutic, they were able to stay at their outside institution. Only if they had anticoagulation or some of the newer anticoagulant or doses of more potent, if you will, antiplatelet agents. And that would move you up to a Big 3. With that modification, everything else from the clinical and structural standpoint stayed the same. And remember, this was made to be easy to think about, right? If the patient's sick and they're comatose, right, that's a patient that's coming. These are largely for patients that have a normal examination or near normal examination where they fit into the Big 1 or Big 2 categories. If you look down at the therapeutic plan, we originally had Big 1 as no need to consult neurosurgery, but we figured in the rollout phase of this, and for our outside providers to be comfortable, we wanted to make ourselves completely available. At other places, the Big 2 category, it was not required in the trials, but we wanted to be available for that. We felt like if there was some type of anticoagulation involved or antiplatelet agent involved, then we would want to see those patients, especially if they had a subdural epidural, we would want to see those patients in follow-up, so we wanted to be notified about them. And then the Big 3 category, those are ones that all needed to be transferred. Next slide. Some of this is what we've already gone over, but essentially the structural criteria for Big 2 and Big 2A are the same. And then the other caveat to this is if the outside hospital has the ability to reverse the coagulopathy, let's say it's from Coumadin and they can give Kcentra, and now the patient's still stable and you've got their anticoagulation reversed, there's probably no reason that that patient would have to be sent. I don't think we need to dig too deep into the medicines that not very many hospitals have, such as Pracbine and Dexa. Go ahead for the next slide. So adapting this to the ICH transfers, we used, instead of 1, 2, and 3, because there's already a scoring system, we didn't want to confuse it with the ICH score. We came up with ICH A, B, and C. And then we also did D, which was for the devastating hemorrhages. For instance, a 90-year-old patient from a nursing home with a 10-centimeter dominant hemisphere hemorrhage, right? We all know that nothing's going to happen with that, so there's no reason to transfer that patient. The volume of the ICH has been shown in many trials to be very significant in terms of what kind of outcome the patient will have. These are also automated within the radiology reports to give an ICH volume. Since more of this is focused on trauma, we can skip beyond this, but from a system standpoint and transfer standpoint, this has been very helpful as well. Next slide. We'll just take a moment on antiplatelet reversal. So at least for intracerebral hemorrhage, a study out of Europe a few years ago demonstrated that there's really no benefit and you have an increased odds of poor outcome with antiplatelet or with giving platelets, and the growth of an intracerebral hemorrhage is not affected. This was not really for trauma. It did not include patients that already had low platelet count, so we still feel like if the patient has to have something done and their platelet count is below 100,000, it's still reasonable to give platelets. But a patient that comes to the outside hospital who's on clopidogrel, for example, does not need platelets necessarily. Next slide. All right, I get to hand this over to Ben now.
Hey everyone, good afternoon. So I was invited to be a part of this collaborative work back in 2017 with Dr. Miles and Dr. Bernard and team, and have been a part of introducing this to the emergency medicine service line as chair of QSOC over the last couple of years. And the emergency medicine team has found a lot of favor in this guideline to support medical decision-making and appropriate disposition of our patients from the ED. What's really important here is how we incorporate our neurosurgery colleagues as consultants, since a lot of these patients do not require transfer. And then how do they interact with us and the EMR to ensure an admitting team at your outlying facility is comfortable with the plan of care. What we've done is work through some of the charting that you saw in Dr. Bernard's slides, which we'll talk a little bit more about, and incorporate and create a tool in the EMR to both help guide the emergency medicine provider in terms of standard communication to the neurosurgeons about scoring, and then to the hospitalists who will ultimately admit these patients and develop the plan of care. All of these were very important in making this process move forward. Next slide, please. As you can see here, this is part of our clinical ED workflow view, and where you would find access to the traumatic brain injury, big criteria scoring and ICH scoring forms. And the important and kind of outputs from this form is essentially guiding the emergency medicine provider in their communication with neurosurgery, and actually helping you with your medical decision-making, incorporating verbiage from the form directly into your charting. So reducing some of the work the ED provider has to do in terms of documenting conversations. It does output whether or not the patient should be transferred to the CMC main versus admitted at the local facility versus discharged home. It discusses whether or not the patient meets criteria for repeat head CT, and then whether or not really the patient requires a neurosurgery consult. For the smallest traumatic brain injury patients, big one, the neurosurgery consult is available and currently being used today. But as we culturally and clinically shift and get more comfortable with these guidelines throughout the region, I suspect the need to consult will go away for the smallest traumatic brain injuries that we've mentioned here. And then what's really important, and what Dr. Bernard mentioned, is the radiology report and the form that Dr. Clemente developed is automatically pulled into this Cerner Power form for the ED provider to access during their scoring. We can go to the next slide, please. This bottom portion here is what the output provided to the ED provider and how we use it is the most important piece. As you can imagine, memorizing all of these categories would not necessarily be feasible, and then posting this kind of guideline throughout your emergency departments across the system wouldn't necessarily be the right way to go. So we enlisted the help of Matt Sullivan and IAS folks, and we've created the form coming up on this next slide. So it does appear a bit busy, but I assure you this is way more simple than it would be if we were tracking on a piece of paper here. You can see in the top right that the radiology report, the CT findings are pulled straight in, and it gives you the exact information you need to fill out this form. All of the criteria that are mentioned on the previous slide are here, and then the output you can see is the bottom portion where it says recommended big score. And this is where we communicate with the neurosurgery our scoring of the patient, although there are some caveats that after consulting with the neurosurgeon, the recommendations may be adjusted. But it recommends hospitalization, whether or not the patient needs a repeat head CT, and then of course, whether or not the neurosurgery consult is mandatory, depending on the score. If you go to the next slide, this is the ICH scoring as well, and it's very, very similar. The output is what we need as well. And if you next slide provides similar information, the radiology report is pulled in, and you march through this power form, and it provides appropriate output. None of this would have been possible without the IAS team kind of doing a last-minute effort to get this done prior to Epic rollout, and we're appreciative of that. And I think this is a big success. It helps us standardize how we're communicating with both the neurosurgeon and the hospitalist. It provides the appropriate recommendations and automatically documents in the EMR, which is exactly what you would want for a form like this. And I believe that is my portion. Happy to answer any questions as needed.
Hey, so Joe again. So we decided to form Access Neurosurgery, and we initiated the rollout on June the 1st. This is essentially a 24/7, 365-day-a-week triage decision-making support with image review. And this is to help our local facilities manage these mild traumatic brain injuries and ICH patients. We created templated notes to document the clinical components, and we have a note in the chart guaranteed and have not missed one within 30 minutes for each of these patients. Actually, I think the very first month we missed one because we didn't have all of our I's dotted and T's crossed, but since that time we haven't. So in the first month, we reduced transfers by 22 patients. We've now, and this is hot off the press as of last night, we've now got 6 months worth of patients. We have saved 140 patient transfers. That's 446 bed days. It's interesting that we have an astronomical number of these patients that are quite elderly. 53% of them are actually older than 80 years old. Nearly, looks like 30% of these either already have a DNR pre-existing, or by looking at their hemorrhage pattern in their coma scale and their sort of family wishes, we are able to convert them to comfort care prior to sending them to the tertiary hospital. Next slide. Oh, actually, you can also see this was for the first month. The hospital systems have remained pretty similar. Actually, Pineville is the greatest transferring center, followed by Union and Cleveland and Cabarrus after that. Mercy, interestingly, is very, very low in terms of patients that have been transferred. Go ahead to the next slide. So we've been pretty lucky with the way this is rolled out. I think a lot of it has been the strong educational team that Lauren Macco and Julia from the Neuroscience Institute have helped coordinate. In the first quarter, we saved $107,000 just in ambulance transfers alone. Over the 6-month period, we've saved almost $200,000 in ambulance transfers and over $275,000 in average day savings for the 6-month time period. We have a quality monitoring program, and as of now, we have had very low rates of patients returning. The vast majority of these are the initial consults. So we've also opened this up so that if a patient stayed at the outside place and got a follow-up CT scan or had some type of clinical change, we could call in and have access to neurosurgery as well with some decision-making. Only 4% of the patients that we've enrolled in this program have required a follow-up consultation. Next slide. All right, I'm handing it over to Lauren.
All right. Thank you, Dr. Bernard. Good afternoon, everybody. So I think we can all understand and kind of hear the common thread or the common gap throughout this presentation, that when we're talking about managing or TBIs or ICH patients locally, there's a concern for that discomfort in managing those patients. And a lot of the standardized tools that have already been discussed was really put in place to help alleviate and address that concern. Understanding that the clinical team is more than the providers making the decision in the emergency department, and that first step, we needed to address the discomfort for the clinical teams at those regional hospitals. Sorry, that might have been me. So one of the key issues that were identified is just the local teams lack that experience with the neurological diagnoses and management. As mentioned earlier at the beginning when giving the history of the project, this project's been going on for quite a while, beginning around 2016, 2014, really getting off the ground and running. At the early stages, it was recognized that nursing was very concerned with managing these patients at their local facilities, so education was developed and disseminated amongst the nursing team, and it was very well received. We used it or disseminated it in a module format. As this project began to get reinvigorated in 2019, if anybody understands nursing workflow, if it's been more than 2-3 years after you first educated, you recognize that it's going to probably be a brand new staff that you have to address. One thing that benefited us, though, when we reinvigorated this was now a lot more of our sites within Atrium were stroke certified. So we understand there's a different mechanism between traumatic injuries and strokes. But what that allowed was just increased comfort in knowing what a neuro patient is, particularly how to do an assessment, how to recognize changes, and what you should do about it. Obviously, the education materials were still available and disseminated amongst the nursing staff, but we found that that wasn't so much a barrier as it was when we initially kicked this project off. Another concern that was brought up was just concerns around the nursing workload changes due to possible increased acuity of patients. And this was really related to not really understanding the expectations in the management of these patients. In order to address that, we led that conversations and discussions with the local nursing leadership at those facilities to work through what these patients actually need, what are on the order sets, what the expectations are for them to understand that these patients aren't all going to need to be in the ICU and take up ICU beds, which is a concern, especially with capacity at all of our sites. Also understanding some of the volumes. When we're looking at these neuro TBI patients and ICH patients compared to their overall patient volumes, this is a rather small subsection of that for their units. So understanding those low volumes, and this necessitates just needing those available resources to increase the comfort. So what we did was create a SharePoint site that was accessible to both nurses and physicians with all of the proper resources, including the criteria that was shared earlier in the presentation, one-sheeters, documents just for real quick highlights of what should be done for these patients, and it just to make it accessible for everybody. And then lastly, as we've talked throughout the presentation, the opportunity for any tools or standardization is key in increasing comfort and making sure that this project is successful. One additional way we realized we needed to continue that model was having a standardized order set for our minor TBI patients. The TBI order set that was currently in place was much more comprehensive and more geared towards the more severe traumatic brain injuries. So we wanted one that was more geared towards the minor ones that really outlined what needed to be done based on that therapeutic plan that was outlined in the criteria that was listed. So all of these things together really helped increase the comfort in managing these patients at the local and regional facilities. Next slide.
Thanks, Lauren. Well, I'm going to kind of close out presentation so we can move into, some time for Q&A and talk about our next steps. But I think one thing I'd say from a system engagement perspective is we really stepped back when we wanted to reignite this work through the work group and identified our key partners. This was not news to any of them that this was an opportunity, but we kind of, as Dr. Miles likes to put, we never let a good crisis go to waste, and COVID created an opportunity for us to really reinvigorate conversations and get leadership buy-in. One thing that we really, we spent a lot of time and energy on, and I want to give credit to Dr. Bernard and Dr. Miles, is on a weekly basis, we set up a feedback tool. And this was this was for the facility leadership so that they would understand how things were going, but also so that they would know, it's not just we say like, oh, you're going to help us with these patients, but they knew like what was working and what wasn't. And we actually ended up finding out that you can see an example here where of the feedback tool that we used, where we said like, this was a productive evaluation, thank you for this and kudos to the team, and really gave them feedback on what went well. We gave a lot more productive than we gave opportunity evaluations, and this helped us. Another thing, Dr. Bernard mentions the access neurosurgery. E-consults are really difficult in this reimbursement environment. Virtual is helping us a great deal, and we definitely use that to be creative on how we could best engage to make sure we had a reliable e-consult platform. And big thank you to Dr. Bernard and the neurosurgery team. And I think the thing that we really wanted to make sure is that there's scalability. We'll go into this in next steps, but there's an opportunity here for this platform to be used in other settings too. So I'm going to go ahead and move us to the next slide. And Dr. Miles, I don't know if you want to help us with the reflections.
Yes, thank you, Sarah, and thank you, everyone. As everyone can imagine in the audience, this effort has taken a lot of work, a lot of consensus building around multiple practitioners, multiple professions and disciplines throughout many of the Atrium Health facilities. Have to give a lot of early credit from some of the initial work in our committee from people like Julia Rutowski, who's part of the Neurosciences Institute now, as well as Jamie Hartz in the administration, Andrew Asimos with the emergency department at CMC Maine, who's really helped in the initial part of moving us forward, as well as Vicki Block, who's the president of Atrium Health in Maine, with the senior executive leadership team a year ago, helping to give the final nudge of approval to help us move forward. And this is a lot of the work we're presenting today. The reflections are important because, as you can see, the effort doesn't stop here. We still need to move forward. And part of it is needing to increasingly demonstrate the value to the system with clinical optimization, the data. As part of the power form that Ben presented, one of the components in creating that will allow us to be able to capture data pretty much at the time it is being used and signed off on, so we can collect that into the system and look at the outcomes along with the access neurosurgery. The feedback process and process improvement is ongoing, and as the resources may be restructured with and during the pandemic, we hope to be able to make that even more robust among the atrium facilities and non-atrium facilities. Looking at the strong adoption and the straightforward evaluations of all of that. Continued work needs to be done balancing facility capacity challenges, such as the bigger Atrium Health facilities, such as at Pineville. Every one of the facilities has capacity issues before the pandemic for the most part. It made worse now. So that continued work trying to balance among the facility capacity challenges is ongoing. Transitioning to sustainability measures, we're able in hardwiring this, the sensitivity specificities of the power form, along with the all of the leadership engagement and made aware of all of these processes. Next slide. And as Joe mentioned, one of the biggest perceptions we had was around the DNR DNI identification. We knew that was a problem with the access neurosurgery for the first 6 months. We really see that it's a huge percent of patients, and that's really one of the next steps is focusing on the communication and improvement of identification. Even with electronic medical records, what we have found is the communication among Atrium Health facilities is not bad, but it's the communication among the skilled nursing facilities, long-term care facilities, other outside facilities to the Atrium institutions, because that communication, even if someone has a goldenrod, sometimes that is not put forth in given that communication and transporting a patient. The palliative care component around the ED facilities when a patient does arrive. We also are looking at the next steps to try to scale this to other initiatives, especially since we have the platform and the people and the institution engagement. And this would be potentially around spine fractures, potentially multi-traumas of other components, as well as non-neuro initiatives. Perhaps some of the cardiac components of looking at keeping some patients with minor cardiac issues more at the other facilities. We're also looking at the virtual triage component of not only how virtual engagement has helped with the pandemic, but trying to broaden that with platforms for perhaps even keeping other patients when we can actually look at the patients more readily at the different institutions, as well as broadening this out to non-Atrium Health facilities. And looking at the hardwire, the appropriateness without any of the detailed case review, looking at the process improvement around that process without having to look at every single case review, and to having that system sort of are hardwired for the future. And all this hopefully will be able to improve the resources and capacity issues among the Atrium Health facilities. I know we have covered a lot today, and I know that there should be some questions from the audience. I do appreciate you all listening to us in this presentation. An hour worth of presentation does not do justice to the amount of the work involved, but I do appreciate all the people in our work group and task force, as well as administration, for helping us move this forward. If there are any questions, please feel free to ask them, either using the chat box or asking them. I know there ought to be some questions here.
Dr. Miles or Dr. Bernard, some of our audience are from outside hospitals that are not part of Atrium. I know you briefly covered it, but what would you say is the top things that you need, or the top things that you've noticed are missing when someone's calling in with a consult or a request for transfer? What would make it more successful, or both the transfer itself and ultimately the patient?
Hey, it's Joe. So I would say the number one issue is being able to view the images. So we, Carolina Neurosurgery, triages patients that have traumatic brain injury and ICH already many nights of the month at Gastonia and Caramont, and every night at Piedmont and Rock Hill. We certainly are open to discussions with other hospital systems, but the fundamental issue is being able to see the images. You know, for a neurosurgery resident, the mantra is, show me the CT scan, I'll tell you the history, and that the images are just very important.
There's one question in the chat box from Sherry Duncan about, is it possible for outside facilities to get copies and some of the tools that have used at Atrium facilities and to help with the local management such as the local management guidelines and order set? I believe so. I will work with Scott Wilson and Sarah Bender about making sure we can distribute those. If anyone wants that information, or we can discuss it, if you could send the emails to Scott or to Sarah, then we can perhaps share those with you all.
Yeah, and this is Joe. And if you guys want to talk to us about how we can, get on board and help you triage those so that they can stay there, right? This is a great deal for the hospitals that are keeping these patients. You get 2 dots of blood in your head, and your DRG goes way up. So your ability to keep those patients locally is very good from a financial standpoint for the hospital that decides that they don't have to transfer the patient. And if those outside places need some help doing that, we'd be happy to try to talk to them and see how we can best help.
Any other questions from any of the audience? Please feel free to ask.
A big thank you to Chian, who just put in the chat. He's one of the facility leaders that has really helped us in helping make sure we get this implemented safely, well, and thoughtfully.
Yes, thank you. If there are any other questions and you don't want to ask them on the audience, please feel free to send an email to us or to initiate any conversation through Scott Wilson. We'll be glad to answer them. And I do appreciate everyone in the audience and to listen, as well as the panelists today. There'll be a lot of more work moving forward.
With that said, I want to thank you again for joining us, and thanks to our speakers. This was definitely a great topic. Recording of this talk will be posted on our website, metroatlantatrauma.org, as soon as possible. And in the future, please join us for our next conference. Next one's going to be on January 19th, and then every third Tuesday after that. We appreciate it, everyone.